and welcome to the show. I am your host, Griffin Sendek. Today we are joined by Dr. Eric Vogelstein and Dr. Alison Colbert.
Hi, everybody. My name is Eric Vogelstein. I'm an associate professor in the School of Nursing and the Department of Philosophy here at Duquesne. And my background is in ethics, ethical theory and applied ethics. And I work in healthcare ethics. And I've written on a variety of interesting topics in the field. I've written a lot on nursing ethics recently. I've written on advanced directives and surrogate decision-making, reproductive ethics, medically assisted dying, and a bunch of other interesting controversial issues in healthcare. So today, I'm happy to be talking about vaccine ethics and the various issues that relate to the vaccine. So thanks a lot for inviting me, Griffin.
Thank you for coming.
My name is Alison Colbert. I'm an associate professor in the School of Nursing. I'm a public health clinical nurse specialist, which means my practice focuses on public and community health, and as has my research. Here at Duquesne, I focus primarily on healthcare of marginalized and vulnerable populations. I'm currently involved in vaccine efforts in various ways, including with Duquesne University's vaccination pod in the Hill District that's being overseen by the Center for Integrative Health.
The topic for today's show is the COVID-19 vaccine and the ethics of distribution. The current phase system, it focuses upon risk factors. And something I want to ask is it really the best decision that could be made? And what other options are there for vaccine distribution?
So you're right that the way that the vaccine allocation priority has worked is people have given the vaccine priority to people who are at the highest risk of the most serious complications, and in addition to some extent at the highest risk of getting the virus. So this is why nursing homes and congregate living facilities, for example, are definitely the best priority because they meet both of those criteria. The virus spreads rapidly in these facilities, and the patients there are the most vulnerable. I agree that there's a question about what to do a little bit kind of down the line, if you will. And that's especially true now, given that the data is in that the vaccines, the mRNA vaccines in particular, very effectively prevent transmission. So from a public health perspective, one might argue whether preventing transmission should be a primary goal as opposed to protecting those who are most likely to suffer from severe disease should they get the virus. So just as an example, we might think that patients who are not vulnerable to severe illness are primary spreaders of the disease. And in the long run, preventing spread of the disease will protect the most vulnerable people by lowering the numbers of infections and by preventing variants from developing that might be more contagious or more deadly. So that is something that a lot of people have considered is, whether to prioritize people who aren't very at risk of severe illness, but are at risk, so to speak, of spreading it a lot, which is somewhat ironic because it means that we're going to be prioritizing perhaps people who are least responsible. But at the end of the day, there's at least a question of whether that would do more benefit than harm.
When you look at algorithms for decision making about vaccine distribution, right? There's all sorts of inputs, right? All sorts of considerations. When you have a limited supply, the algorithm looks different, right? If you had ample supply, right? If that was not an issue, how you rolled it out, how you did it may, follow one direction that may be able to be this broader public health. We have the infrastructure. If you could get it this way, right, you could really focus on transmission. When there is a limit to the vaccine, that changes the decision making, right? So when we start to prioritize people, it's the understanding that we're allocating a pretty scarce resource. The other consideration that comes up, of course, is that, are vaccines public health or individual health? Are vaccines about protecting the health of the public or protecting the health of individuals? Both, in my opinion, they're both, right? And so that's the other decision about algorithms about vaccine distribution, right? Obviously, herd immunity as a public health nurse is the primary goal. The system by which we do it needs to protect the health of the public, but we're also talking about protecting individuals at the same time, and that's what complicates it in many ways.
Could it be said that focusing on those above 65 that are opposed to younger generations, in some ways, this early rollout has been wasted focusing on generations that aren't as prone to spreading the virus?
I would not say wasted. I think there are we're getting darn near 560,000 people have died from this disease, right? I mean, part of the consideration is that the protection of human life, again, with a scarce number of vaccines, prioritizing those who are at most risk makes the severe disease and death makes the most sense to me.
Yeah, I think there's, I would leave it up to other scientists to do the calculation, because there is a calculation to be made here. I'm not sure if the data is in to make it, but we can run the numbers and see, in terms of probabilities of various outcomes, probabilities of transmission, what the most, what the most number of, for example, life years saved might be from different allocation schemes. I don't know if that has been done. It's a difficult thing to do, not only, mathematically perhaps, but just based on whether we have the data to do it. As far as prioritizing people, we didn't know about the transmission issue until very recently. So at the beginning of the vaccine rollout, it was reasonable to remain agnostic about the extent to which the vaccines prevented transmission. And therefore, the argument that I just made before about prioritizing people who are at low risk but high transmission risk doesn't really apply, right? That applies more now that we have those data. And, nor can we assume that 65-year-olds are just going to be sitting at home all day. I mean, that would have to be something that that's an assumption. Perhaps a 30-year-old is out and about more. Maybe that's a fair assumption, but how much more, and whether, how much more that contributes to transmission, and how much we can rely on vaccines preventing transmission at each point in the rollout. I think we did things fairly well. I do, again, to reiterate, I think now that we know that the vaccines prevent transmission almost as well as they prevent in symptomatic disease, we need to take seriously that method of developing herd immunity as quickly as possible and preventing transmission to everyone. And there is a question about, whether, how important are the rules? What's more important, getting the vaccine out as quickly as possible to as many people as possible, or being sticklers for the rules and making sure that only the most vulnerable people get it at any given point in time, and then we move very meticulously to the next group? There's a trade-off here. New York State was notoriously bad at this. They were big time sticklers for the rules, and vaccines went unused. Vaccines were thrown away, and that I think is the most unacceptable outcome. So I do think that there is, I would favor a little bit more of a liberal vaccine distribution policy now that we know that these mRNA vaccines in particular, Pfizer and Moderna, are excellent at preventing transmission of the disease.
And I think you have to be a little more, the data are not the same for the transmission as they are for efficacy or the decrease of risk. I mean, there's advancing knowledge that it reduces transmission. That big study that just came out from the CDC on Monday, very encouraging for reducing transmission, but they're not at the same level, right? We're still really are looking at the transmission. So we are getting a little bit more information about how good it is at transmission. Having common goals is complicated, right? So when you pick a distribution strategy, the question is transmission or deaths, right? Those and they point to two different directions. I think that not every area is the same, right? Allegheny County has a very high, over 65% of the population is over 65, right? And so we may do allocation differently than other areas. It's tricky for all of those reasons. And there's, no super clear right answer, especially when you're talking about a completely novel virus. Like it hasn't been in either any of the three of us lifetime that we did this really, where we introduced a new vaccine to the system, brand new in this way. We're testing the system in a lot of ways. And this disease acts different than other ones. So, it's very unusual where children are not at risk. It's unusual. And so, we're learning a lot from this particular process.
What would be the ethics of, like, right now turning to what I call the lemonade stand approach, that you just pop-up distribution centers on every possible street corner and give them out to absolutely everyone, throwing away phases altogether and just really being a free-for-all of, if you want it, come get it.
I think the devil's in the details here. I mean, we're almost there, Griffin. Honestly, within a month, we will be there. We'll be at the point where, in most states in the country, at least, the vaccine will be available to all adults. That's the trajectory we're at. That's the benchmark Biden administration is set of May 1st for that. And we're even a bit ahead of schedule there. So at this point, there may be the infrastructure and the vaccine availability and the immunization of the most vulnerable already. There is nothing wrong with that right now. Now, whether that would have been the right approach to take from the beginning, I don't think so. I think you have to look at factors other than just getting the vaccine to as many people as possible. I mean, if you look at two possible schemes, where one, you get the vaccine to as many people as possible, but in another scheme, you prioritize and maybe you don't get it to as many people as possible as quickly, but it's only 1% fewer people than you otherwise would have, then the amount of life years saved, the lives saved, is definitely going to be in the favor of that second prioritization. I mean, there is going to be a trade-off. Prioritization means having rules and logistics and bureaucracy, which slows things down. But there's no reason why that it has to slow things down so much that it makes it not a worthwhile thing to do, given that we're protecting the most vulnerable people first.
And it's not just the prioritization. I mean, this is a medication administration, right? This isn't just, you roll on by and get an injection, right? And somebody's with a license is giving you an injection. There's documentation issues, there's keeping track of things. And further complicated by this is a 2-dose regimen, right? So your lemonade stand has to be back in that spot in 4 weeks if it's Moderna, in 3 weeks if it's Pfizer, right? I mean, it's a complicated sort of thing. And then you have to do the documentation, and it needs to be in there clearly. We got to track who's having response and who's not. That, right? This isn't just about handing out cups full of pills, right? This is an actual, this requires multiple levels. And, my boss, the dean of the School of Nursing, says there are people who can complicate a cup of coffee, and healthcare providers can do that, right? I mean, and so we've certainly done that to a certain degree. For me, there's always a huge elephant in the room, which is we've spent many, many years defunding the public health infrastructure. So the idea that the public health infrastructure can handle this strain without, at this point, without a massive investment, we are paying the price for that. Part of the issue here is that we deprioritized and defunded public health, and we have done that for years. Public health departments are shrinking, allocation of resources towards things like outbreak investigation, these things, the funding for all of this has gone down. And hopefully our memory will not be short on this, so that we will use these lessons to invest in the infrastructure. Time will tell. I think the vaccine rollout could have been better, could have been smoother had the public health infrastructure been such that it could respond in that way. But I think the vaccine rollout specifically, I think where we could have mitigated, had the most effect in terms of mitigation efforts, would have been earlier on. And, honestly, I think it's going to be the longer term effects, right? So some of the issues we have is the politicalization of COVID response, right? And so vaccine uptake is going to be very much affected by the political tenor of the conversation around COVID. So we'll see that more over time. Right now, we have a lot of people who want to get vaccinated, but we're going to get to a point where we've got those who are ready and confident to be vaccinated are vaccinated, and we're left with people who are hesitant. And that's going to be a remnant of the initial handling of the COVID crisis.
Yeah, this is in my mind one of the most bizarre and fascinating, in a macabre sort of way, facets of the pandemic is the politicization of public health measures, not just the whole mask issue, which is really a machismo response to being told what to do. Right? People don't want to be told, but even if it's raise your hand and I'll give you $1,000. Oh, don't tell me to raise my hand if I don't have to. Doesn't matter how beneficial it is for them or their community, right? That's an amygdala response, not a rational one, but it is based on political culture. The vaccine issue regarding politics is what I was referring to. And this is just, it's frankly bizarre. If you look at the statistics, 50% of those who are registered Republicans say they're not going to get the vaccine or are very hesitant to get the vaccine. And like 90 something percent of registered Democrats are going to get the vaccine. Where does that is on its face, an extremely bizarre result, especially given that the prior Republican administration at the beginning was touting its success with regard to the vaccine. That seems to have gone out the window. I'm not quite sure why, but this is a problem. This is not about education. This is not about vaccine hesitancy in any normal sense. This is something deeper. This is about political culture and the divisions within America that put us into these different tribes that cannot be resolved by just educating people more about the safety and efficacy of the vaccine. This is about community, and it has to be done from the bottom up.
Certainly. So right now we're focused on a supply issue, that there's more demand than there's supply, but eventually that will flip and there will be a lot more supply and a lot less demand, and it will be difficult to get a lot of these people that are very reluctant to take the vaccine or just flat out don't want it. This would never happen, despite what some conspiracy theorists might believe, but what are some of the ethics of just forcing every single member of the population to be vaccinated?
Yeah, can we just put this in the water supply? Is that an option, Dr. Colbert?
Yeah, sure. We don't know how that nanotechnology works. I mean, the question of force, right? To some degree, we do in certain ways, right? You want to go to public school, you want to come to university here, right? Certainly people have opportunities to opt out, right? But there are places where we say you have to have the vaccine, right? There are elements of that already in place. The police powers of public health, which are very real and written into the Constitution, right? When we are protecting the power of public health, there are things that the government can do. That's how we have stay-at-home orders, right? I mean, that's where those things come from. Extending those to vaccines has all sorts of problems. And as you said, I don't ever see that happening, but I would leave it up to Eric about sort of conversation about what the ethical considerations of that are. As a healthcare provider, I don't give people medication that they are not consenting to. There is no forced administration of medication. You are not going to find a healthcare provider who's going to do that, right? So that doesn't exist.
Yeah, I predict that the vaccine will be mandated in all of these institutional settings, universities eventually, schools once it's approved for use in children. I believe that's coming. Like Alison said, we mandate other sorts of vaccines. I don't think this is any different. There's no vaccine right now that's more important that people have. I mean, we mandate vaccines for conditions that have no prevalence whatsoever anywhere near communities. And so the reasons for mandating COVID vaccines in all of these settings, I think, are compelling. In terms of forcing people to take it, yeah, I mean, this is a version of being forced. It's a coercive force. It's saying, either take the vaccine or you don't get A, B, or C. It's a mild version of coercion because we're not saying we're going to do something to you. We're going to say we're going to not allow some privilege to be given to you unless you have this vaccine. I think that's a difference. And we're certainly not physically strapping anyone down and injecting them. We do this with other public health issues as well. Tuberculosis is the prime example. If you refuse to be treated for tuberculosis, you can be quarantined against your will. We take public health to be one potential area in which your rights or your freedom might, not extend as far as you would like because you're at risk of harming other people, right? Your rights end where harm to other people begins, at least given that the harm is significant enough. So personally, I am in favor of that. I don't even think it's particularly controversial. We do it already. This is a serious condition. We know the consequences of not having, a population who's immune. Herd immunity is essential to get back to normal life. So I see very little ethical problems with mandating a COVID vaccine in all of the sorts of institutional settings in which we already mandate other types of vaccines.
Let's shift over a bit to the culture around the vaccine and vaccine shaming, which has procured a lot on social media. Like throughout the pandemic, there's been many examples of different shaming, whether it's mask shaming or shaming people from going to parties and stuff. But the vaccine shaming is very, very different, it feels. Why are people so adamant of questioning whether people really deserve a vaccine, of their question of all these qualifications, and why has some of this popped up as an issue? If you guys
So let me just say one thing, and then I'll give it to Alison. Human psychology plays a role here. I'm going to say jealousy has some role to play here. When you see someone else get a vaccine and you want the vaccine, and you don't like the fact that they, did what was necessary to get it, or that, they had some lucky happenstance way of getting it. I mean, that's, I think that might be part of it. I assume what you're referring to here is someone who is shames another person for getting the vaccine too soon.
Mm-hmm.
Yes. So, this is a situation where I think one response is hate the game, not the player. There's, as long as a person doesn't cheat, doesn't skirt the rules, as long as they act within the rules, especially given that it is possible that vaccines might go to waste, and at the very least delaying vaccine distribution means a slower rollout overall. So if they're in line and someone doesn't think they should be, and they say, I'm going to take the high road and refuse the vaccine. Well, if everyone did that, what would happen? It would slow down the entire process.
Yeah, I mean, I think there are two different questions, right? There's the people who are outright fabricating underlying conditions, right? And then other people feel like shouldn't actually meet the criteria. There are some really big issues here for me, right? So the ideas of worthiness, right, is one of them, right? Who's worthy, who's not, right? That gets really complicated whenever we allocate scarce resources, especially healthcare resources that have to do with protecting people's lives, right? So whose life do you protect? There's a lot of like stigma and shame in healthcare in general, right? And we have to be really careful about that. We have to be careful about ableism, right? If your disability is not visible to me, then it does not exist. It's not an acceptable stance to take either, right? It gets really complicated. There's a lot of really fraught issues here. And so whether or not we're going to pay a lot of attention to people we think are cheating the system in order to get the vaccine. I mean, I think people are afraid, people are tired, people are exhausted, people are not used to dealing with other people, right? I mean, maybe who knows how much time it's going to take for us to get back up to speed and being in the world. It's not going to serve anybody, right? I think to Eric's point that, the system is new and fragile and difficult and not great in many ways, right? So there's a lot of room to criticize, which is fine. We'll do it better next time, right? Shaming individuals, though, gets us to a place, for the most part, that's ableist, comes from a place of fear.
And that's not to say that there's no controversial criteria. That's fine. We can debate those criteria.
Yeah.
And I think that's important to do. But yeah, I don't quite relate to the shaming part. Now, that doesn't mean I don't understand where people are coming from. If they want the vaccine, they're sick and tired of this. They're very pro-vaccine. They've been taking care of themselves and doing the right things the whole time. And then, to take an example, this is a controversial one. And actually, I do think that there are some healthcare organizations that have done wrong in this manner. But healthcare organizations, and this is debatable. I know there's arguments on both sides, but healthcare organizations that give stay-at-home clerical workers who work for them priority, right? So suppose someone gets that. I understand the reaction to be angry at the person. I don't think that's the right reaction. I think you need to take a step back at that point and say, well, wait a second. Maybe I do think there's an injustice here, but I can't blame them. If someone is offered the vaccine, I think you don't as a individual, you don't second guess the rules. You don't take it into your own hands and say, well, I don't think the rules that the government has set down are correct, so I'm going to, be a kind of a vaccine vigilante and set my own rules personally and be a saint. I don't think that makes sense.
Mm-hmm.
I think you follow the rules. Everyone gets the vaccine according to the rules the government set up, and that speeds it up in the way that we need it to be.
We can reserve judgment about individual decisions, right? But there's a lot of structural inequity that we do have to be worried about, right? When we think about who's getting cheated, right, that's where our attention needs to be, right? What is the public health infrastructure? What's the system doing that's not reaching the most vulnerable? That's who we have to hold accountable, not the individuals who are trying to, from their own place of fear or whatever, right? We have to focus on how do we access people who need the vaccine but are not getting it, right? So for too long, it was that you had to get an appointment via the computer, right? There's a lot of people who are going to be left out of that. And these sort of amazing grassroots things came up, people were registering other people, but that's not okay. And we have to pour our resources into the structural inequities, right? And what we know are the real problems of quote unquote cheating come from that, not the individuals that we're concerned about.
Yeah, and to some extent, this is, it's an uphill battle because of just the nature of technology. Technology makes things easier. That's its point. So what happens when the rollout first is initialized? We do what makes it easiest, which is to use technology that is not accessible to more marginalized groups. That we need to do things that are not necessarily the easiest so that we can reach people in an equitable way.
So you guys have touched a bit on cheating the system, and I want to get into that. So just yesterday, I learned that apparently you can walk into a Giant Eagle, tell them you're a healthcare worker or have a pre-existing condition that qualifies you, and they can't question it, and you can get your vaccine. And I know 2 people that do not qualify that just got their first dose. I'm curious to hear your thoughts on this.
Here's an interesting question. I don't know. Is it better to cheat the system or never get the vaccine? I'm not sure that's a relevant question. It's an interesting one. I mean, it puts things into perspective, perhaps. I don't know the answer, but I mean, I do think it's wrong. At least if the rules are reasonable. There has to be a damn good reason to lie in order to make lying okay in this sort of situation, I would think. Now, should Giant Eagle be required to require proof of one's pre-existing condition? I don't think so. I think that would be just an onerous process that would bog down distribution.
So I have a 17-year-old son who has an underlying condition, autoimmune condition, takes medication, compromises his immune system. And we had this sort of interesting conversation, right? About, he was advised at the very beginning to go get the vaccine. We got a letter, which they automatically generated for him to get it. And so we had pretty clear parameters. We had a letter, we sort of did some consternation around it, right? He's 17, all of those sorts of issues. We did our own sort of internal, and all the recommendations were like, he should go get this. And we were very worried throughout the whole time because he takes these immunosuppressant drugs. We went to get the vaccine and nobody asked. Nobody's ever asked. Nobody asked what he had. Nobody asked anything else, right? That was not part of the process. And I have thought about this a lot. Like, should somebody have asked, right? Or was it enough, right? And that's what they said, do you have an underlying condition? They didn't ask any specifics about it, right? And so I have my own personal, I was surprised, and I've actually worked on the other side, and we don't require it, right? It's not one of the things. So the issue starts to become about policing other people. So what if it is that you're a smoker? What if it is that you have a BMI over 30? BMI is sort of a dumb measurement anyway, right? Like that,
Yeah.
So like all of these things about it, right? Like it's like one of the, there's these sort of lines in the sand, right? That we're not going to be able to design a system that primary function is to prevent people from lying to get a vaccine. right? And so it can't be that the system is designed that that's even one of our priority interests. Prevent people who are lying from getting the vaccine, right? It's just not the way that you can do something like this efficiently. You have to trust that people have some sense of the collective good. That's where we get back to some of the political questions, some issues like that people have been told for many years that they don't have to think about the collective, right? They've bbeen told for a long time, you know, individuals, that's what matters, individuals, that's what this country is based on. And in my opinion, that's not true, that you know, there's so many people who are all about the collective good. And that's how we have to design the system, I think.
Well, this is the perfect example of the way in which those two things overlap. I mean, what's good for an individual is going to be what's good for the collective. If we want society to be back to normal, we need to make it so collectively. That's the only route.
Yeah, with my way of looking at this, it's on one hand, it's lying and cheating and wrong and can potentially be taking away doses from those that actually qualify, that, and you could say, are in need of these. But on the other hand, more vaccines in arms is better for the collective. It's safe for everyone. And the more vaccines in arms, the faster this pandemic can potentially end.
I might struggle a little bit with that. Here's what I'll say about that. That, like, I think we're not going to rationalize people who lie.
All right.
Okay. Like if the criteria is wrong, right? I can get behind that. Like, yes, we're going to be fairly generous with the interpretation of the criteria. If somebody who's not a healthcare provider walks in and says, I'm a healthcare provider, they're in the wrong.
And I agree.
Yeah.
And I agree that they are wrong. But if, in their opinion, telling this lie can potentially save their life and the ones they love, I feel like for a lot of people, that's worth it to them to be in the wrong and to tell that lie.
So yeah, this is a conflict between what are called special moral obligations that you incur based on your relationships with others, whether that relationship be the fact that you've made a promise or commitment to someone, a professional role or obligation that you have, or family, right? Close friends, or your obligations to your family are greater than your obligations to strangers, whether that outweighs the sorts of public health considerations that justify, you know, not lying to get the vaccine. Yeah, I mean, I think this is an interesting question. I mean, you might say, well, yeah, I'm not in the current priority group, but I'm going to protect my family. That's my primary moral obligation. I don't think this is a trivial question. You know, I think what matters is where we are in the priority group and who you're taking the vaccine away from, and the extent to which those rules actually make sense, like Alison said, whether the priority groups are right or wrong. I mean, if you're taking this away from a nursing home resident, that might be, at the very least, I think, more wrong than taking it away from someone who's farther down the line of priority, who isn't as high risk. It could be, and I don't have a strong view on this, but it could be argued that, you know, everyone has their own obligations to their family, and they have to take that into account. You know, if
with a scarce supply, I mean, again, all that's true with ample supply, in my opinion. Scarce supply, I think there is. You have. I mean, in order for you to be part of the collective action, the idea you have to be willing to agree to the general principles that other people are agreeing to.
I agree with that. This creates something of a prisoner's dilemma, I think, where, you know, if everyone else is doing the wrong thing, you're going to get screwed over, so to speak. Part of what matters here is the extent to which other people are cheating or not. If everyone else is cheating and you're being the saint, you're not a saint, you're a sucker.
Well, we sometimes have a, you know, tendency to talk about these things, but I've been in a lot of clinics. I just spent 4 hours in one today. They are full of people who are completely eligible, people whose family members are bringing them in, people whose you know, grandparents who come in with Band-Aids that their grandchildren sent them, right? And said, please wear this Band-Aid, right? This is not what's happening. Yes, there are examples of it. Yes, it's an interesting thing to debate and discuss. And yes, you know, when you work in a clinic, you know, you're asking some questions. There are some things about that, right? That, this is not the predominant problem. The predominant problem is making sure we have ample supply. We're making sure that we are getting to hard to reach places. To use your lemonade stand as an example, we're making sure that lemonade stand gets on the road, right? That it's going places, that we're putting money into doing those things. We need to save all of our outrage and injustice and hours of debate to make sure that that's the kind of thing that's getting attention. I'm less concerned about the person who's lying about being a healthcare provider. Individually, it pisses me off. It bugs me as a healthcare provider, right? But again, we're getting later in the, there's open, we have this debate all the time. There are 10 doses in a vial of the Moderna vaccine, right? You've got 2 left sitting there. Better to go into somebody, and we're always doing the math and find somebody to put this in, right? Those are, there's all sorts of questions. But if we need to save our kind of outrage and our debate for these bigger questions, we need to be asking why early on, we still need to be asking what happened with the PPE. We still need to be asking about how we're going to fix this, what the public health system is going to look like going forward, and how we're going to deal with the depression, the sexually transmitted infections, the people who are not seeking treatment for all of their other problems. Like, we've got a lot of things where we can focus our energy rather than this one.